Hi friends, welcome back to BJ's Clinics. I am sure you must have watched the previous video which is on the principles of clinical case taking. What is the most important part of clinical case taking? History taking. Okay. What is the second most important part of clinical case taking? It is history taking. And what is the third most important part of clinical case taking? It's again history taking. So guys, it's history, history, history. Sir William Osler said, if you listen to patients carefully enough, they will tell you the diagnosis. So do you need any more emphasis on how important a good history taking is? So let's get started. History means the story of the patient's illness. History taking may be broken down in three sections for the purpose of clarity and convenience. Basic information, narrative history, that is essentially the chief complaint, and interrogative history. Interrogation means what we ask in further details, and it consists of the present, past, personal, and family history. Now I will discuss all these headings in details. Under this heading of basic information, note down the source of history and reliability. The source of history usually is the patient, but can be a family member, friend, bystander, or a medical record. Reliability varies according to the patient's memory, mood, IQ, and trust. The judgment of reliability is usually made at the end of the interview. It reflects the quality of information provided by the patient. If the patient didn't appear reliable, you may note a comment in the case sheet like, the patient is vague or inconsistent when describing symptoms, or the patient is unable to specify details, etc. Then go to identifying data, which consists of the name, age, gender, residence, occupation, diet, and marital status. The name gives personal identity. What is the significance of age? Certain disorders occur at specific age groups. Sometimes the age alone can play a decisive role in arriving at the diagnosis. For example, Wilms tumor of the kidney, acute osteomyelitis, etc. are the typical diseases occurring during infancy. Similarly, certain disorders are more common in specific gender. For example, thyroid disease, gallstone disease more commonly affect women. Residence is important as certain diseases are endemic in some geographic areas. They will vary from country to country, state to state, and district to district. Just to give an example, endemic goiter is common in the Himalayan range of mountains. What is the role of occupation? Certain occupations are known to have a higher risk of developing certain disorders. For example, varicose veins are more common in jobs involving long hours of standing. For example, traffic police constables, salesmen, nurses working especially in operation theatres, and surgeons. Hepatitis B, AIDS, tuberculosis tend to affect medicos and paramedics. Ischemic heart disease tends to affect those who do stressful managerial level jobs. People doing strenuous hard labor work tend to suffer from hernia. Please don't get misled here. Everybody doing a particular job will not necessarily suffer from the disorders which I mentioned. The cause of any problem is usually multifactorial. Occupation plays a role of one of the predisposing factors. It is exceedingly important to know about diet. We in modern medicine unfortunately simply fail to go beyond knowing whether the patient is vegetarian or non-vegetarian, and that's it. Remember, the root cause of a significant proportion of even the so-called surgical disorders lies in inappropriate diet. Diet has been given immense importance in Ayurveda, the Indian ancient system of medicine. Look at the common disorders in which surgery may have to play a role in the treatment: peptic ulcer disease, pancreatitis, gallstones, urinary stones, etc. All these disorders are basically medical to begin with. And what is the root cause of all of them? Inappropriate diet in some way or the other. I hope you agree with me. So that was in brief about the basic information. Now we proceed to narrative history. Narrative history essentially means the chief complaint or complaints plus listen patiently to whatever the patient narrates in the flow. Do not interrupt unless the patient wanders too much. What do you mean by chief complaint? It is the symptom which bothers the patient most. Note down the chief complaints in chronological order of their occurrence. That means the symptom which occurred first gets on top of the list and then the subsequent symptoms lower down the line. Verify the exact site and duration. If you do not verify them, you may get misled. How do you verify the site and duration? Well, that is expected to be taught when you present cases during your clinical rotations. There is a lot of such things which can be taught effectively during case presentations. Actual physical case presentations are always the best. But if that is not happening in your college for whatever reason, then they can be taken online. Anyway, then ask, is this the first time that you are suffering from this problem, or else is it recurrent? Certain disorders are typically recurrent, such as appendicitis, cholecystitis, pancreatitis, pain of peptic ulcer, etc. Never mention or write two symptoms in one sentence. For example, avoid pain in abdomen and fever for 4 days. Instead, prefer pain in abdomen for 4 days, fever for 4 days. Okay? Do not write a long list of symptoms under the heading of chief complaints. A surgical patient usually has only one or two chief complaints, occasionally three or four, and rarely more than that. And the third broad heading of history taking is interrogative history. This is how you interrogate. Ask the history of present illness, past history, personal history, and family history. Okay? Present, past, personal, family. Simple. Let us discuss them one by one. History of present illness is the crux of interrogative history. You must master the technique to unfold the history of present illness. This is the way it goes. Elaborate each chief complaint by asking its mode of onset, progress, and regress. Ask additional relevant symptoms. The relevant symptoms logically will vary from case to case. Then ask the review of symptoms, that is, common symptoms related to major body systems, followed by the last menstrual period if applicable, followed by addiction, followed by treatment taken if any for the present problem, and finally any long-term medication on which the patient has been otherwise, that is, for any problem not related to the present one, such as antihypertensive, antidiabetic, antitubercular, antiretroviral, etc. Let us see how to elaborate chief complaint. Logically, the first thing you ask is how did it begin? In technical term, what was the mode of onset? Was it sudden or insidious? The mode of onset is said to be sudden when the symptom gets established in few minutes or hours. Intensity of symptom is severe and loss of function is marked. Now, what do you mean by this? Marked loss of function. It means the patient is compelled to stop work and take rest, or may even take to bed soon after the symptom begins. The mode of onset is said to be insidious when pathology has been present for some time before symptom is perceived by the patient herself or himself, or else pointed out by a friend or a relative. And what are the criteria? Apparent duration is in days or weeks or months or years. Intensity of symptom is mild. Progress means increase in the severity of the existing symptom or sign, or development of a new symptom or sign. When the symptom or sign progresses within minutes or hours, the progress is termed dramatic. Examples are anaphylaxis, perforation of a viscus, sudden kinking or twisting of an organ, etc. When a disease progresses over days or weeks, it is said to be progressing rapidly. Acute inflammatory conditions progress over days, malignancies progress over weeks. Slow progress occurs over months or years. Cysts, benign tumors like lipoma, chronic inflammatory conditions like tuberculosis, actinomycosis, etc. progress slowly. Some lesions attain a stationary status after having progressed initially. For example, lipoma, neurofibroma, etc. One more example is peptic stricture of the esophagus. Sometimes a disorder may slowly progress, then remains stationary for a few years, and later may start rapidly progressing. What will you think of if this happens? Think of malignant transformation of a benign lesion. Regress means a qualitative or and quantitative decrease in the severity of symptom or sign with respect to its nature. For example, regress in size or intensity or frequency, etc. Size is the parameter applicable to a swelling, ulcer, etc. Intensity is applicable to pain. Frequency is applicable to, say, vomiting, diarrhea, urination, etc. Regress usually, though not always necessarily, suggests improvement in condition. Additional relevant symptoms. What do you mean by that? The word relevant suggests that there has to be a relevance of these symptoms with the chief complaint. And the clear-cut aim of asking relevant symptoms is to find out the system, organ, structure, or tissue that is affected, and pathological nature, etiology, and complications. Is there a ready-made set of relevant symptoms available? Well, in general medicine, orthopedics, ENT, obstetrics and gynecology, etc., yes, it is. But in general surgery, we deal with so many systems, organs, tissues from head to toe with different pathologies affecting each one of them that it is practically impossible to have a ready-made set of relevant symptoms. Then, how to derive the relevant symptoms to ask? Simple. Look at the chief complaint. Think of the possible pathologies which can give rise to that chief complaint, and if required, take into account any additional information that you get after examining the patient. So, in case if you cannot derive relevant symptoms only from the chief complaint, then you can always come back for the second round of history taking after examining the patient. During physical examination, you will often find clues enabling you to derive relevant symptoms to be asked. Relevant symptoms may be classified as case-specific and general. I will talk on case-specific relevant symptoms while discussing various clinical topics in the videos which I will be uploading in future. Loss of appetite, loss of weight, and fever may be called general relevant symptoms as they are applicable in many surgical disorders. The loss of appetite must be distinguished from fear of eating caused by, say, gastric ulcer or inability to eat consequent to a disordered mechanism of swallowing. In gastric ulcer, appetite is not lost, but the patient is afraid to eat because eating initiates the pain in abdomen. Loss of appetite is invariably accompanied by loss of weight due to diminished protein calorie intake. What are some common causes of loss of appetite? Tuberculosis and malignancy in general, and diseases of the GI tract and accessories in specific. Objective readings of weight are often not available. In that case, how will you ask for the history of loss of weight? Have the previously tight-fitting clothes become loose now? I will discuss the causes of weight loss in the class on general examination. What are the common causes of fever? Infection, including occult intracoelomic, for example, intra-abdominal abscess, drug reaction, cancer, including hematologic malignancy like lymphoma, etc., inflammation, including autoimmune disorder, and dehydration. The review of symptoms are the symptoms related to major body systems. These questions may uncover problems that the patient has overlooked. The list can include a large number of symptoms. In practice, however, you need to ask only those questions which are of practical importance and which should not be omitted or forgotten even in a busy clinic. And this is the list of those symptoms which you must ask in each and every case. You have to know the list by heart. Shortness of breath, diminished exercise tolerance. These two symptoms are common to both respiratory and cardiac disorders. Cough suggests predominantly respiratory disorder, whereas chest pain suggests predominantly a cardiac disorder. Now see how the combinations of these symptoms help you to fix the most probable site of disease. If a patient complains of shortness of breath and or diminished exercise tolerance plus cough, he is more likely to have a respiratory problem. On the other hand, shortness of breath and or diminished exercise tolerance plus chest pain most likely suggests a cardiac problem. Alright? Then ask if the patient has been having hypertension and diabetes. How will you ask the patient if she or he is suffering from a bleeding disorder? You have to articulate a question which patient will easily understand. Do you get easy bruising or bleeding on even otherwise a very minor injury? Or in case if you get a small injury that bleeds, does it take too long for bleeding to stop? Ask if the patient is allergic to any object in general and to any drug in particular. Note one very important point here. Hypertension and diabetes should be considered as the present problems. Many books on clinical methods put them under the heading of past history, which is wrong. Hypertension, diabetes might have been detected in the past, but once detected, they are almost always lifetime companions of the patient and hence come very much under the heading of the present problem. It almost never happens that there was hypertension or there was diabetes and now they are not there, unless they were present for a short while due to a temporary period of extraordinary stress. It is important to know the last menstrual period and possibly the one before that for two reasons. That may give an idea if the patient is pregnant. During pregnancy, you must avoid taking X-ray of the abdomen and also the medications which have deleterious effects on the fetus. And the second reason is that in case if you are planning an elective operation in the pelvic region, say for example an interval appendectomy, better do it after the bleeding phase of menstrual cycle is over, because more oozing of blood occurs due to pelvic congestion during the bleeding phase of a menstrual cycle. And these are the points to be asked under the heading of past history. Any childhood illness, jaundice, tuberculosis, pneumonia, any operation done, suffered from any accidental injury, and ask the details if the patient suffered from any of them. These are the points to be asked under the heading of personal history. Sleep, bowel habit, bladder habit, history of immunization, and personal interests and lifestyles. And under the heading of family history, ask for any hereditary disease running in the family and ask about the age and health of siblings, parents, and grandparents. So that's about history taking. To quickly recap before winding up, history taking may be broken down in three broad sections: basic information, narrative history, and interrogative history. You must know the points to be asked under the heading of present illness by heart. There is no doubt that all these points are important in their own way, but elaboration of the chief complaint and the relevant symptoms will crack the case. Thank you for watching.